For this lecture, we're going to discuss some of the other calculations that are used within the clinical laboratory in order to ensure quality assurance is being performed. So we're going to cover Chapter 14, the Comprehensive Laboratory Quality Assurance. So diagnostic sensitivity is the probability that only patients with a disease will test positive for that disease. And so when we look at the diagnostic sensitivity, we have to look at it in the analytical point of view as well as the clinical point of view. Within the analytical point of view, the lower limit of detection for a given analyte is what we're talking about. So what is the lowest level of that particular substance or element in that patient's sample that we're looking for in order to consider the patient as having disease? And then we're also looking at the clinical aspect of it, so the proportion of the people with the disease who actually test positive. And when we're looking at the diagnostic specificity, this is the probability that a patient who does not have that particular disease will actually test negative. And so that means in order to have the best test out there, it needs to have 100% sensitivity. It needs to be able to detect the particular analyte we're looking for. And it needs to have 100% specificity, meaning if it tests positive, it means that that patient has the disease. So the sensitivity and specificity of a method is what we often will look at when we're analyzing different methods to determine whether or not we're going to use it in our laboratory, or determine whether or not, if a company is making a new test and they want to determine whether they want to present this to the market, and then they're going to promote their sensitivity and specificity for this test because we want to get as close to 100% accuracy as we can. And so in order to do that, they will use these calculations where they're looking at the sensitivity and specificity, which is based off of true values or true positives as well as false values or false negatives. So we got to look at the true positives, true negatives, and the false positives and false negatives. So what a true positive is that the number of individuals who actually have the disease will actually test positive for it. I mean, that's what you expect. If they got it, then they should test positive for it. False positive means this is the number of individuals who don't actually have the disease, but for some reason they're testing positive. So this could be interfering substances or other diseases that can have some cross-reactivity with the test method. So there are a variety of things that can cause false positives, but we're interested in the true positives as well as the false positives. And in the same respect, we're also interested in the true negatives. So the number of individuals who don't have the disease and they test negative. And then we're also going to look at the false negatives, which means the number of individuals who actually have the disease, but for whatever reason they're testing negative. So there are a lot of things that can cause this, someone to test false positive or false negative. So when looking at a test and determining whether or not you're going to use that test, we're going to look at all these different values. So what do we do with this data? How do we use it? How do we determine sensitivity and specificity? So let's just say a manufacturer develops a new kit for group A strep or strep pyogenes, that is the bacteria that causes strep throat. And so what they're going to do is they were looking at 600 pediatric patients that were presumptively diagnosed as having group A strep. So out of those 600 pediatric patients that they evaluated, 475 of those patients tested positive using their new kit. Of those 475 patients that actually they got a positive test, then they further evaluated those patients, and 460 of those patients were verified by culture that they did indeed grow strep A or group strep A strep pyogenes. 125 of those children tested negative. So, they were presumptive to have strep, but 125 of those children tested negative for using that kit. Of those 125 children, when a culture was performed, 20 of those children did have the infection actually grow on the culture. So that that gives us our values that we need to determine our true positives, false positives, true negative, and false negatives, so that we can kind of start evaluating our sensitivity and specificity. So looking at those numbers again, the 475 children that tested positive for this kit, they were cultured, and only 460 of them actually demonstrated a positive culture or grew out the strep pyogenes. So that is our number of true positives. Now remember that 475 of them tested positive by kit, but only 460 of them confirmed positive through culture, which means 15 of those positives were actually considered a false positive, meaning they did not grow the bacteria, so something else caused that positive reaction, that false positive reaction. Now, the 125 children that tested negative, they were also cultured, and 20 of those actually presented with a positive culture. So that means that those children really did have strep, but for some reason the kit didn't detect it, so it gave false negative. So that false negative result is 20. And our true negatives, we now know that of 125 of those children, 20 of them really did have strep, which means only 105 of those children actually tested negative or true negative according to the kit. So here we have our equations again for sensitivity and specificity. So we just plug those values in to get our results. So for our diagnostic sensitivity, our true positives we determined to be 460, and our true positives plus our false negatives, we had 460 plus 20 false negatives. Remember that we cultured those negatives, and 20 of those children did grow strep pyogenes. So it's 460 divided by 80, which gives, and we multiply that by 100, and that gives us 95.86. So yeah, it kind of sounds pretty sensitive. It sounds like it would be, pretty sensitive to detecting that bacteria. Of course, there are some things that can cause those false negatives, like not getting an adequate sample, a variety of other things, like if the patient had drank or ate before that sample was collected. So there are a variety of things that can cause those false negatives, but 95%, it's, still we'd like it to be as close to 100 as possible, but still not too bad. But when we look at our specificity, we talk about our true negatives. So the ones that we determined were definitely negative via culture were 105. And then, of course, those false positives, we did have some that tested positive. We're not really sure why, but they did. We worked that out. It gives us a specificity of 87.5%. So we know that we have a sensitivity of 95.8 with a specificity of 87.5. So that specificity for determining whether or not a patient has strep pyogenes is a little low. So not sure if this company would be ready to take this test kit to the market, because there are some that are a little bit better out there. Now, in order to take that sensitivity and specificity a little step further, we have to talk about the efficiency. So the efficiency is the number of patients that are correctly diagnosed for a particular disease or not having that disease based on those true positives or those true negatives. And so we can use this calculation to help determine that. So we look at the true positives and the true negatives against the true positives, the false negatives, and the true negatives. So we look at all of that data together and we get a percentage. So looking at the previous kit, we were talking about, we'd already determined our true positives and our false positives, true negatives, false negatives. So all we have to do is plug those values in, which gives us 94.2%. So the efficiency of the new test kit, 94.2%, actually not too bad when you kind of look at it overall. But again, we like those numbers closer to being perfect, correct? So now we're going to talk about a predictive value. So with our predictive value, a positive predictive value means that we have the ability for that method to correctly determine the presence of the disease in a patient who actually has the disease. So patients who are positive for that disease will test positive by this particular test method. And of course, our negative predictive value would mean that that same method can correctly determine the absence of the disease in patients who do not have it, so meaning they are truly negative. So patients should test negative by the test method in order, the test method that is designed to detect a particular disease. And so for the positive and negative predictive values, those equations are listed here, which of course are going to use the true positives and the true negatives against the false positive and the false negatives. So here we have an example. A new assay was developed, and the manufacturer is promising that it's going to detect prostate cancer way before any sort of symptoms ever developed. So because they're claiming this, they're basically stepping out there and saying that it is more sensitive and specific than the other tests that are out there on the market. So they've got to do the studies and they've got to present the data to prove this. So the blood samples they collect from 10,000 men who are asymptomatic for prostate cancer are tested. So out of those 10,000 tests, 8,000 tested negative. Out of those 8,000, 30 of them later did develop the prostate cancer. 2,000 actually tested positive, and then of those 2,000, 1,900 actually developed prostate cancer later. So this would be a long-term study. A lot of times before any kind of test gets put out there to the market, it has to go through a lot of testing processes and approvals. And then the data has to be put out there. It has to be calculated, proven. So obviously, in order to test this many people and follow them for a length of time to determine if they ever do develop the disease, these studies have to be done for a long time. So it does take a very long process for new test methodologies to be approved, to go through the FDA process of approval, and to actually be put out there, presented to the public, and put on the market to actually be tested or used to test patients. So these companies have to prove that they've done all this testing, they've done all these calculations, and that this test will actually prove if someone does or does not have the disease and what the false rates are. So when doing these calculations for this particular method, when they've evaluated and continued to follow these patients even after the original testing, they've determined the value of the true positives, or the positive predictability value, to be 95% of the patients. If they test positive, then there's a 95% chance that they will actually develop prostate cancer. That's a pretty good predictability there. So CLIA does require that for any kind of new test methodology to be put out there into the market, that it has to go through several processes. And part of that is for any sort of test that is unmodified, FDA approved test or FDA cleared system. So when we talk about unmodified, meaning you don't make modification to it, how the manufacturer says is how it is. So you have to demonstrate that you can obtain the performance specifications comparable with those established by that manufacturer for the different performance characteristics. So we got to look at accuracy, we got to look at precision, and we also have to establish reportable ranges. So anytime you're going to bring in a new system into your lab, you're going to run it how the manufacturer says how to run it. You got to make sure that you've evaluated and established accuracy, precision, and you've determined your reportable ranges for your area, the people that are in your area, your population. And so you have to use a little bit of what the manufacturer gives you. You got to either verify their reference intervals or their reference ranges, their normal values, to make sure they're appropriate for your patient population. So there are a lot of studies that happen before you can even bring a particular kit or test methodology into your laboratory. Now, occasionally, there are laboratories out there, especially like reference laboratories or research laboratories, that may use some test methodologies that aren't approved by the FDA, or maybe modifications have been made to that particular method that the FDA has not approved yet. And so before you report out any of those results, there are a set of criteria that have to be used. We did see this a lot with COVID testing, because COVID testing was so new and it was rolled out so quick, where the manufacturers did not do those studies like they should to determine those true false positives and false negatives. So we did see a lot of this happening over the past several years with a lot of different methodologies, because everyone was looking for a quick fix to determining if someone had COVID or not. And so a lot of stuff got rolled out really quick. So from that point, it's up to the laboratory to determine all of those criteria, because the manufacturer didn't do it. So if you develop a particular test, or you modify something you're doing in your lab, you got to make sure that you've ran through all of these checks. So before reporting out those results, that test system or methodology has to run through all of these calculations you have to do to make sure that it is accurate, precise. You've got to determine the analytical sensitivity and specificity. If there's anything that interferes with it, for example, with COVID swabs, did mucus interfere with it? Did blood interfere with it? Those were all questions when we were working in the lab that we were trying to determine what interferes with this test, because stuff was rolled out so quick, they hadn't really evaluated all of these interfering substances. What are the reportable ranges? You've heard a lot of talk about PCR testing and those reportable ranges of where's that cutoff? Where exactly do we put that cutoff? And then considering, what's considered normal. Is it normal for somebody to have a little bit of this particular analyte present? At what point do we determine that it is positive, or what point do we determine that it is negative? And of course, you have to look at any of the performance characteristics that are required for that particular test to perform. So you've got to look at every avenue of that particular test methodology. So another rule that I want to point out that's very important in the clinical laboratory that we do is kind of one of those behind the scenes things that happens, is that if you have different methodologies or instruments in your lab, then you have to prove, or even if you're testing at multiple sites, you're using the same instruments, but results are coming in from different sites that are all still flowing into the same patient record, then you've got to make sure that you evaluate those against each other. So a lot of us are already familiar with, most of our laboratories will have, for your higher volume tests, so let's just say in hematology, your CBC analyzer, you usually have two analyzers. You have either the exact same analyzer, you just might alternate days that you use it, or you may have your core analyzer, but then you have a smaller one that's kind of used as your backup analyzer. So you have to be able to compare those two analyzers and say, it doesn't matter if I run tests on this one or this one, I'm still getting results that are really consistent with each other. So you have to do those validation studies at least twice a year to make sure that your results are staying consistent, regardless of what analyzer you use or methodology you use, or if you're testing at a different site. You've got to prove that you've validated that you're getting consistent results regardless of what you use. So when we talk about a laboratory determining accuracy, or even a manufacturer determining accuracy of a test, we're basically saying, how accurate is this test? How close are we getting to the actual true value of whatever we're looking for? So there are studies that are designed that will detect any sort of systemic bias between from different methods. So in other words, if you're doing a urine test by manual dip versus an automated dip, we got to compare to make sure that we're getting consistent results, that we are accurate no matter whether we manually did it or whether the machine reads it. So to do this, we usually analyze about 20 to 30 samples over a set period of time, and we're looking at a particular reportable range for that method of both the old methodology or the new methodology. It could be that you're bringing in a new machine. You know, your current machine is getting a little old, so you're bringing in a newer machine that's going to be a little bit faster, test more samples. So you got to compare that old method with this new method. And so most laboratories will use different computer programs to do this now, but it can be done manually. I would not recommend it. A lot of math, but it can be done manually. You can do those calculations. But you do have to prove accuracy, especially, like I said, if you're changing instruments or anything like that. You got to prove that the results you were sending out on the new method matches the results of the old method. So a laboratory may have to do accuracy studies. This is not something as an MLT that you will necessarily need to do. I just want you aware of it, to know that there is a very extensive process that goes into determining accuracy of testing, beyond what you see from your day-to-day, just putting the samples on and doing the QC. There are studies that are done behind the scenes anytime you bring in any kind of new method or anything. And so one of those that's going to kind of help determine any kind of systematic errors is going to be a recovery experiment. And this is basically it's designed to determine whether or not proportional systematic errors exist in any sort of method. So you'll evaluate 20 to 30 samples that you're going to aliquot out into 2 samples. So one of them is your reference aliquot. The other one, you might spike it with something to see how it interferes. So, and then you're going to test it, and you're going to see, you know, if the results are consistent, is anything going to interfere with it. And so basically these studies are done in replicates just to see how something affects something. So again, this isn't anything that you've got to learn or know about. I just want you aware that there are studies that are done. And so this is really actually going to be something that's more going to be done by the manufacturer. But if you're working at a reference lab or anything that maybe they're developing their own methods, you could potentially see this happening. So another study that could be done would be an interference study. Again, it's kind of similar. You're looking at things that might interfere, like bilirubin hemolysis, any kind of lipemia, medications, contrast, anticoagulants. So anything that they can think of that might interfere with a test method, they're gonna use that as part of their study to see how does it affect the results. So with accuracy, we're looking to see how close to the true value we get, and then when we're looking for precision, we're looking at how can we repeat this? Can we repeat this over and over and over again and get the same value? So there are studies that can be done to determine precision. So precision, is determined by looking at the standard deviation and the coefficient of variation. So all those calculations that we learn how to do, this is where we bring them back to look at some of these things of precision. So CLIA mandates that precision studies have to be performed as part of a method validation. So you may have to do this within your laboratory. So it could be within a run study to help determine if there's any sort of random error that can happen, or it could be between the run study to help you determine if there's anything that's happening with the analyzer. So again, this is not something that you will probably ever have to do, but just know that these studies are done. Now, laboratories do have to determine the reportable range of a particular analyte or method, or the linearity of that method. So you want to see what range can that machine, what is the highest level and the lowest level of that actual analyte that machine can read without any kind of modifications done to it, and those results still be accurate and precise. So what you're going to do is for any kind of moderate or high complexity test system, you're going to have to determine what the reportable range is, or the linearity of that machine or that analyzer. And so we do this by analyzing the low and the high calibration material or the control materials, something to determine what it can report as. And you can also do this by looking at, taking known samples that you've already ran. So maybe you ran them, you're getting a new machine, you ran it on one machine, you've got those values, you know what those values is, so you're going to repeat those same specimens on the new machine, and you're going to record that data, and then you're going to plug all this data into a nice little system that's going to help you figure out what your reportable range is. And so it is required that you do a minimum of 3 replicates of at least 5 different concentrations over that reportable range. So your manufacturers may tell you what the expected reportable range is, but you still have to determine for that particular analyzer in your facility against all your environmental elements, everything. You've got to look at it all. So you got to see what it's doing in your facility. So this is done by some grafting. If the patient's results are actually higher than the reportable range, then that means that some kind of modification is going to have to be done, some sort of dilution, or you rerun it. And of course your laboratory would have to determine, are you going to do the dilutions, do the equations, or is it just something that you can report out as greater than or less than? But your patient values have to fall within the limits of whatever is set. So once you determine this is the lowest point that this machine can read and be accurate, and this is the highest point it can read and be accurate, then you know that your patient values have to fall within that range. So now when we talk about reference intervals, this is what we often refer to as the reference range for the patient results. So what is considered our normal range of results? So you do have to do studies at your facility because you got to look at your population in your area. Let's just say you're a facility that's in a retirement community. So obviously that 60 plus population are going to have different values than, let's just say, an area where your population age is a little bit younger. So maybe you have an area where there's younger generations with young children. So their values are going to be different than, let's say, this facility that only serves that elderly population. Those values of what's considered normal is going to be different. So you have to establish it for your particular area. Other things that can factor in would be things like gender, race. All these things can kind of factor into what's considered normal for your population in your area. Each area, the demographic regions have different ethnicities that are in that area, so that can affect results. So you've always got to do these studies to determine what's going to work for your area. So the Clinical Laboratory Standards Institute recommends that you use at minimum 120 samples from the different populations that you're going to be analyzing to determine exactly what reference ranges you're going to set. Again, this is something that's typically already going to be done before you even get into the lab, but occasionally if a lab is bringing in new analyzers or anything like that, or new methods, they're going to have to set these up for their area if they're bringing in a new test to consider, look at what's normal for our area. Just because the textbook said this is the typical normal value does not mean that's what's normal for your area. So your lab will go through analyzing those samples to determine the mean, getting those standard deviations, and setting up those new levels or reference intervals. So another thing I want to make mention of is proficiency testing. So proficiency testing, you'll often hear us refer to it as PT testing, which is kind of redundant, proficiency testing, but your PT samples, somebody might say you have a PT sample to do today. So what that is proficiency testing. Do not confuse PT with patient. You got to know the context in which the acronym is used in. So proficiency testing is actually another additional tool for quality assurance. And so what this does is actually assess the accuracy and precision of a laboratory's method and their instruments. And so CLIA mandates that at least 3 times per year for any moderate or high complexity laboratory or test method that you actually do some sort of proficiency testing. And what it is proficiency samples are made by an outside source, outside company, that they will send you these samples, you analyze them. So it's kind of like a test, like an exam. They send you these samples, you analyze them in your laboratory just like you would a patient, and then you send those results that you get back to the agency, and then they have different criteria that they have in place for whether or not they're going to accept your value. So you're looking to make sure that you're getting, they know what the value is, so they're trying to see, do you get that value? And so what they will do is actually plug your information into a set of data along with other individuals or other institutes across the country, world, who are also evaluating this material. At the same time, they're sending in their results. So you get a comparison against your peers, as well as you get an evaluation of your results. And so there are some different values that we look at. Of course, you need to pass, and there are some criteria there that determines whether or not you pass. If you have a failure, you do have to address it. You do have to make notations and investigate why that failure happened anytime you get a result incorrect. But what you're looking at when you're looking at those results and comparing them with your peer results is there's a standard deviation index formula that is used that looks at your results compared to your peers' results. So it just kind of gives you a report card of where you stand in the bigger picture when you're comparing yourself or your laboratory against other laboratories.